Now, we would like to return to our speaker for our traditional City Club question and answer period. We welcome questions from everybody, including guests. Holding the microphones today are Operations Assistant Mika Tadashi and Director of Community Relations, Missy Toms. And now for our first question, please.
At Case Western Reserve University School of Medicine, we have a HUD-supported program where we go out into the inner city to our elderly patients' homes and inspect and provide hands-on interventions to make those home environments more healthy and more safe, obviously fall prevention. Does your department support these sort of optimizing the home environment for our elderly? Is there a mechanism to do that?
Yes, we've done several things. As a matter of fact, when I used to be down at the community level administering these programs, we really needed, we're not, like I say, we're not healthcare providers, but we're in the business of health. And the delivery mechanism and the network that I administer is really a human service kind of support network. But we know that we can't do it alone. The healthcare that people need, other than obviously healthcare and medical care, they need some other kinds of support. And prevention is critical. I can tell you that we have funded over 30 states right now using evidence-based prevention programs. I think right now, in a matter of balance is being used right here in Case Western University, right here in Cleveland, as a model for falls prevention, which costs upwards of $30 billion a year. In medical costs. But the important thing is that what we're trying to do is bring it down to the community level and train lay people using the fidelity and the science that has been researched out of these wonderful chronic disease management, falls prevention, and really train people at the community level to empower seniors to take care of themselves. We just don't need physicians to go to people's homes to pull the area rugs out of their homes or help them look at what are the alarming signals of people falling. We need community people, we need volunteers, we need a lot of people to understand that this is something that they can do by themselves. I mean, so we're educating, and yes, this is a funding source that we've been funding for the last, since 2003. And we have been joined, we're very proud that we have been joined by the Atlantic Philanthropies and the John A. Hartford Foundation, which has accompanied our federal dollars with an additional, I think, $15 million. So yes, these programs are being implemented, and right here in Cleveland, we'd love for you to get together with Ron Hill, which is sitting on this table, and being able to work together. And the exciting part about it is that we're generating incredible partnerships at the community level between the medical schools, the research and teaching institutions, the professionals, and then the community workers in creating these being able to take our best science in simple tools that we can empower people to manage their chronic conditions, including preventing falls. Thank you.
Ms. Carbonell, you spoke about the high cost of medical care for the elderly, and certainly one of the very important parts of that high cost is the cost of prescription drugs. The President's program provided for a rather complicated insurance program that has a donut in which you fall between it, you get nothing, and you get something earlier and something more later on. Many elderly have found that they can still buy drugs from Canada for a lot less than what they would pay in the United States. They come in the same packages as the manufacturer, they're authentic. 27 million Canadians do very well on those drugs. Why does the administration still say it's illegal for Americans to buy prescription drugs from Canada?
Thank you for your question. I want to share that I under Secretary Tommy Thompson, which I've served under Tommy Thompson and now Mike Levin, I served as the consumer advocate in the drug reimportation task force. So although a very complex subject and extremely difficult to answer in a quick bite, one of our most major concern, obviously, is the safety and security of the medications. That's number one, overriding. The second issue, obviously, is the issue, number one, that, we're extremely proud that for the first time in history, over 40 million older Americans and disabled Americans have access to a benefit that pays for prescription drug benefits. As a matter of fact, the prescriptions and the cost of the care of Part D is more than 35% under the projected cost of what, the projections were made in the budget for the cost. Not only are seniors saving, they are extremely satisfied with the service. The other thing which you mentioned, which is important, is that, of course, we did not have the resources available to cover everybody for all the costs. What this Medicare Part D provided was to ensure that we level the playing field and that all Americans on Medicare would have the ability to have an added benefit that would cover their prescription drugs. And for those that had high prescription drugs, to make sure that they had 100% reimbursement of their drugs. They're built into the system, of course, as some of these bills go through Congress and all the reiterations, sometimes they come out, like you said, at the end, kind of complex, And this was the first time that we had implemented a program in such short period of time to such large numbers of people throughout this country. So it was a historic opportunity that I was thoroughly involved with over 40,000 events. But the most important thing was that that is tailored to be an individual. It's tailored to serve the individual, including in providing the benefits. There was a clear coverage that needed to happen for people that would hit that gap in coverage until Medicare kicked in at full 100%. So there are plans throughout every region in the country, including the state of Ohio and right here in Cleveland, that you can purchase coverage for that gap. So there is, right now, every individual that has higher cost and that they hit that gap much sooner because their cost or they are taking multiple medications, they can actually choose plans and tailor their plans and benefits based on the individual needs, medical use of those of the individuals. The other important factor is that as part of the new Medicare modernization, one of the important things that is being carried out is, for the first time, we're beginning to pay for prevention. And certainly medications is part of it, but it's not all of it. We wanted to be able to, really devolve the healthcare relationship between the patient and the physician, and to devolve that responsibility back to the physicians who are in the best position to make that decision for that individual patient in front of them that they're caring for. So it is definitely, it was a difficult but a historic opportunity to do so. People are pleased with the program. People are paying less than we were paying before. There was people that had to decide between buying medicine and buying food in the past. This is not the case. For people that really don't have the coverage, there's other free benefits that are available. And we look forward to continuing to work to find those people that we have had a little bit of difficulty, and Ron knows about it, people that are eligible to receive the additional subsidy, where the co-pays are much less and the premiums are either zero premiums or limited premium coverage. And so we're in the track right now to make sure that we don't miss, and there's no gaps in communities where we know that are highest risk and that we know that they're eligible to receive the additional benefit, but they have not signed up for it. So thank you for that comment.